Thank you. Dr. Majumdar and Dr. Dattro is not here. So myself, Dr. Prashant Ghosh, to start the session. And now the speaker is Dr. Arup Haldar, and the subject is what next after CPAP failure. Dr. Haldar, please.
So what next after CPAP failure? So we have many sessions on it, and I will just put some ideas, and this is just a revision of what we have learned in the whole conference actually. So I won't call it a CPAP failure actually. This is a rather harsh term, and there is no accepted definition of CPAP failure, but we have a definition for CPAP compliance, and this definition is given by the Medicare and Medicaid services of United States of America, and they use CPAP compliance as use of CPAP for more than 4 hours per night for more than 70% of the night. Now, I usually follow these lines that if you learn from your defeat, you haven't really lost, as failure is not opposite of success, it's a part of the success. So in my lecture, I will not tell you what to do after CPAP failure. I will try to convince you what we can do that there is no CPAP failure. So failure, usually I divide this failure into these 3 categories. It may be failure on the patient part, it may be failure on the doctor part, and it may be a failure on the machine part. That means from the patient part, whether the race has any implications. One study has proved that African Americans have lower CPAP compliance than the Caucasians, but this is more related to the socioeconomic status rather than the ethnicity. In India, we do not have such studies. The disease severity, actually CPAP failure doesn't relate to the AHI of the patient, but is more related to the Epworth sleepiness scale. That means if the patient is symptomatic, he is going to use the CPAP more often. Nasal resistance, we'll devote some time on that. Claustrophobia, this is one of the big symptoms. Many patients complain of claustrophobia when we put them on oronasal mask. So there are certain tricks to overcome this claustrophobia. So what we tell patients that keep the mask before time, just feel the pressure for 5 minutes, then when you're comfortable, then put the mask. And we always try to decrease the oronasal mask to a smaller one if possible for that patient. Psychological factors, if the patient have any psychological disease, then it is very difficult to adhere to any CPAP therapy. Then from the doctor part, what is the most important for all of us is the counseling. Before prescribing a CPAP, we have to counsel the patient meticulously and sincerely. And it has been seen that if we can incorporate a cognitive behavioral therapy before CPAP prescription, that often increases the compliance with the CPAP. Now, choosing the adequate pressure. If you do a manual titration, if the pressure is not adequate and if it doesn't comfort the patient, then the patient is not going to use that. If you are using an APAP titration, we have to be more cautious because there may be leak and there may be excessive pressure. We have to see the data from the APAP machine, whether these are present, and we have to change according to that. Proper interface, this is another important factor. The machine doesn't remain in contact with the patient, but the interface remains. So interface should be comfortable for the patient's use. Now, choosing the right machine. Certain patients are not the candidate for CPAP or APAP. We have to give them a BPAP if the condition is satisfied, like the patient of COPD, patient with a higher carbon dioxide level. So you have to choose the right machine. Humidification. So this is not routinely done in our practice, but if the patient complains of a dry mouth or dry nose after getting a CPAP therapy, we have to give a humidifier also. Advanced setting like the C-flex, F-flex, all these settings actually increase the comfort of the patient, but no RCT has showed that they increase the CPAP compliance actually. And if the patient develop treatment emergent sleep apnea or complex sleep apnea after treating these obstructive sleep apnea, he may be non-adherent to the CPAP therapy, and we have to diagnose and treat that also. Okay. So there are some predictors which patient is not going to use CPAP. So what are the predictors? The pattern of adherence is established early within the first week of treatment. So if the patient uses it for the first week, then he is going to use for the next of his for next few years, definitely. Greater score on Epworth scale suggests the patient is going to be tolerant to CPAP. Claustrophobia, we have a modified fear and avoidance scale. If it is more than 25 on that scale, then the patient is not going to adhere to CPAP. And percentage of time less than 90% of oxygen saturation is independently associated with predictor of CPAP failure, because that suggests if the patient remains less than 90% for most of the time, that suggests patient may have hypoventilation also. So those patients are not going to be tolerant to CPAP, or we may have to shift to BiPAP for them. Now, nasal resistance is one of the important factors. So nasal resistance or obstruction with increased nasal pressure results in 50% greater chance of rejecting CPAP. Now, as Dr. Dindal sir is saying, that acoustic rhinometry can be used to measure the internal nasal dimension, and it can be used as a surrogate to see whether the patient is going to use CPAP or not. And surgery should be done if the nasal resistance is higher, even after using various therapies to decrease the nasal resistance, like the inhalation corticosteroid and all these things. But we have to remember, self-reported nasal stuffiness not associated with any nasal dimension abnormality is not associated with CPAP failure.